Welcome to this first webinar arranged by the Dorset Care Record with our sister organisation, the Wessex Care Records, designed to begin the establishment of a series of resources for shared care records to utilise as they develop and move to maturity. The first of these webinars covers communications and engagement, and we will be looking at how we've gone about our stakeholder and partner engagement work, our dealings with media and social media, some of the pitfalls we've faced and how we've overcome them, and what's next to Dorset. And importantly, I've also provided 10 take-home messages that hopefully will be useful for comms and engagement specialists or project managers. These can also be seen in a separate video. Most people working around the health and social care fields will know that the government has tried over a number of decades to establish shared care records. In fact, the first government-sponsored electronic record system involved a small pilot not far away from here in Exeter in 1972. Huge amounts of money have been spent over the years, with one of the dividends being the creation of the summary care record for primary care. A number of these care records are pretty mature. The Hampshire record, which is now called Care and Health Information Exchange, CHI, was started by 2 GPs in Winchester in the 2000s and has now more than 150,000 patient records accessed every month. Bristol's Connecting Care is another mature record, which currently is working with prison services and care homes. All the care records on the slide are working with the New Zealand provider Orion Health. So we had a slower start than Hampshire and Bristol, but for history buffs, Dorset submitted an NHS Integrated Technology Fund bid back in July 2014 and was awarded a grant the following March to go ahead with a procurement initiative under the local authority's Better Together programme, joining up with the then Sustainability and Transformation Plan and Digital Roadmap. Orion Health was chosen as the preferred supplier in July 2016 and the contract signed on the 31st of March 2017. The first feeds, demographic feeds from GPs, were introduced a year later and we were green to go. This was a slide that we used 4 years ago and it's pretty much stood the test of time. Acute hospital information, including referrals, encounters, discharge medications, clinical correspondence feeds are in the DCR, as are community and mental health feeds from Dorset Healthcare. Primary care information, some adult care, social care records, but still a little bit more work to do on the ambulance and hospice care home links. We'll talk a little bit about the patient healthcare record a little later. So when I arrived fresh-faced from 13 years in the civil service via the Campaign for National Parks, Trussell Trust, Dorset Agricultural Society and others, one of my first tasks was to communicate to our partners the importance of the DISC, the Dorset Information Sharing Charter, which effectively underpins the Dorset Care Record, providing a framework to enable information sharing to take place effectively and securely, and it's absolutely key for practitioners and the public. So who are these practitioners? Well, we've got around 7,500 licences available to our Dorset partnership, and that's made up of primary partners. So that includes University Hospitals Dorset, formerly the Bournemouth and Christchurch Hospital and Poole Hospital, Dorset County Hospital, Dorset Healthcare, Dorset Clinical Commissioning Group, which looks after our GP practices, and the 2 local authorities, Bournemouth, Christchurch, Poole Council and Dorset Council. So moving on to engagement. This section looks at what we've done, what we do, what works for us, and what is sometimes a little bit more tricky. As part of the overarching communications and engagement strategy, the leadership team were rightly concerned that we needed to win hearts and minds with our partners. We've already seen the DISC slide, but we needed to assure them that they could and indeed should want to share information safely and securely. This has always been at the heart of the DCR, and that's why we still have a mandatory Digital 2.0 module that practitioners need to pass to get access to using our record around information sharing and security. This has meant over the years many meetings across the partnership explaining the rationale behind the DCR and its benefits. But we also needed to raise awareness to as many people in Dorset, including hard-to-reach groups, about how the DCR might impact them. So the team, and it really has been a team effort, spent many long hours in howling wind and rain and gales, but also in sunshine at times in village squares, car parks, outside libraries, and sports community centres, selling the DCR. One of the questions in the early days that kept reoccurring was around communicating to staff and people about our initial belt and braces consent model and the ways people could opt out. And more about that a little later. So our approach was to do both partner, so that's internal comms, and external comms with residents. Sometimes we got the balance right, sometimes perhaps we erred in the early days too much on getting across messages to the public. If we did, we were soon put on the right path by the comms leads across the Our Dorset partnership. Whatever we did, my mantra has always been that it's far better to be open and transparent and on the front foot than closed, defensive and secretive. So what tools have we built up over the last few years to help us? Well, we've got a variety of leaflets, some conventional from the talented Hampshire-based CAMEG Davies Fleming, and some easy reads. So we had some real co-production work, which we'll touch upon a little later, with People First Dorset. We spent many hours working with staff and members in seminars and workshops to ensure that everyone could understand what DCR is about. We've got a variety of shapes and sizes of posters, pop-up banners, which are invaluable really in local authority and reception areas, GP waiting rooms and hospital areas. Case studies. We now have nearly 60 case studies of users from across the partnership, and indeed some from members of the public, which show how the DCR enhances patient safety, reduces admin, is easy access, but also allows real change. So pathways altered, appointments not needed, an experience different, but because DCR lets change happen. We've also got think pieces or blogs, videos, and quite a lot of social media work. So we've already talked a little bit about some of the aspects of face-to-face engagement, but it's worth mentioning that we carried out pre-COVID a range of surveys on whether people had heard of us. Some said yes, some no. Whether people would be prepared to share their data. Responses were that people thought this was done years ago. Yes, of course. Yes, certainly to my GP and hospital clinician, around 70 to 85% said yes, consistently. But they were much more wary of social workers at local authorities, only 40 to 50% sort of support in sharing there. And why? Because of the belief that social workers are linked to social security and they'll cut my benefits, won't they? Worth mentioning our research into why people didn't want to share their data. Tellingly, perhaps given recent concerns, there was concern and fears about selling the NHS patient data to the private sector or the US. There was also concern about people who were libertarian, didn't want to share their information at all. Followed closely by those who said, well, I'm very well, I've always been very well, I've got very good genes, not the wearable type, and won't need NHS services. To those who simply weren't interested. You can argue against some of these, notably that Tesco's has far more information about you than the NHS ever will, but perhaps not against all. So one of the things to consider is the power of friends and colleagues talking up the DCR. So with partner communications, I think it's always best to join someone in the organisation who is A, a disciple about the DCR, B, knows everyone, and C, is very popular because it makes your life so much easier. This is Michelle at BCP, who works in the Deprivation of Liberty Safeguards Doles team. She's a great evangelist for the DCR. Leaflets are really useful. People quite like to have glossy leaflets. It must be the shininess of them. We've also spent a little over the years on merchandise. I know it's not everyone's cup of tea, and I'm always conscious of not wasting taxpayers' money, but having a pen or a trolley ring or a small torch gets people to stop and talk, and you're in. As I've said, we've worked with People First Dorset since our inception, and in particular Jack and James here with Lisa. James has been a fantastic supporter of the DCR, speaking at our inaugural conference about the need for people to understand his situation better and how records could do that. It was brilliant to see the reactions of some of the county's clinicians and consultants, and he got a huge ovation. And with Jack, he produced a brilliant video for us. We really need people like Jack, James and Lisa. Stories tell 1,000 words, and case studies can be very powerful, particularly real human interest tales. This is Simon, living in Canada, who came to us very grateful that staff at UHD were up to speed with his record. Data really does save lives. Some of the more frequent users of the DCR have been hospital pharmacists who feel that as the DCR has matured, it now offers more than other systems. Information is invaluable, and with the advent this year of single sign-on for our partners from the electronic patient record system, it's making a huge difference in terms of time savings too. So just to round off the section on engagement, here's a recap of some of what I've just said. It's worth mentioning the importance of keeping FAQs up to date. Our helpline has been invaluable, and we get calls every day from colleagues across the partnership wanting advice or resetting passwords. But it's often a good early warning system where people start ringing up and saying they want to opt out. Have you missed that story in the Echo? Is someone stirring things up online? We also send up to our 30 stakeholders a twice yearly update on our work, as well as in the past speaking regularly at patient participation groups, the Dorset Public Engagement Group, Race Equality Council, and charities such as Age UK, MinCap, Seasiders Cancer Trust. So, media and social media. This is actually a shorter section. I've done less media management work than I had envisaged. I suppose having worked as a chief press officer on climate change for a government department, I had unrealistic expectations, but there has so far been little reactive work, which means on the positive side that we can be proactive and look out for stories and events. It's important that if you've got a story to tell, tell it. And thanks to Orion Health, we were able to speak at the prestigious King's Fund breakfast event at its annual meeting in November 2019. It's great to be able to speak at wider audiences and let people know what is happening, and it led to a splurge of positive news stories from health tech press. So here's two stories that are slightly creative. No, I'm not spinning, but they might not have seen the light of day without a bit of spit and polish on them. The one on the left is from Digital Health, and it's about us working with CCG's Blue Prism technology around robotic automation, which basically has been really helpful in providing GPs with click-through access to the DCR thanks to automation technology based on software robots or AI workers. People love a robot story. It must be something to do with Doctor Who, but it has garnered us some great publicity. The one on the right is from our local paper, the Dorset Echo, and is based on a couple of milestones: 3,000 trained staff and 40,000 records accessed. Sure, it's not a front page story, but it has a lovely quote from the 3,000th user, consultant gastroenterologist from UHD. Had a picture, it's open and transparent, it's positive, and it shows movement in the right direction. It's essential though, if you're doing radio or TV interviews, to have qualified spokespeople who are keen, eager, upbeat, and are happy to do media, and who are the right lines to take and are well briefed. On the left here is Andy Hadley, our newly retired technical architect, who was perfect if the interviewer wanted to delve into the technical side of the DCR. On the right is Andy Cowling, our head of service, who again knows the DCR like the back of his hand. Media training, particularly for radio and television, is very useful, and you soon get to tell who's a natural performer and who will really struggle under the lights of the camera. And so to social media. Think carefully about which channels you ought to pursue, and it should be obviously around your key audience. What demographics are you aiming for? If it's for a younger audience, do you have the materials for Instagram? If you've got loads of stories to tell, do you want to do this on Facebook? And if so, who's going to run this 24/7? Are there enough techie people in your team happy to pull together videos for YouTube, upload and promote? If you look at shared care records around the country, they tended to go for a mix, but if you do, you must have content. Of course, you can use the same story on different platforms. We're currently finding LinkedIn for our business audience getting the best returns, but we're really proud of our 1,500 plus Twitter followers, a community we hope, and we want to add to our YouTube channels. As we move to our patient health record, MyDCR, we'll be introducing Facebook too. So, we do a lot of things, and carrying on the social media theme, we also have an intranet site for partners, which includes a raft of training materials and a closed YouTube channel to include videos on navigating the DCR, sensitive records, GP records, HTML viewer, recording a discussion to view, and our diabetes pathway. This is something that partners hard pressed for time really like and is well worth considering. Again, ensure that you have the resources and time to dedicate to this. I've been leading the training as well as the comms engagement for the last 4 or 5 months, holding weekly training sessions. It can be time consuming, but also rewarding, particularly if feedback is good. Always listen to your customer and be prepared to change at pace. Ongoing evaluation is so important in whatever media work you do. And so on to pitfalls, or elephant traps as I call them. These are areas, hopefully, that by doing some horizon scanning won't come home to bite you, as you've got mitigation processes and train. While in the civil service, much weight was placed on this, and it really is much more than gazing into the crystal ball. You need to look at how the government is dealing with shared care records. Are there any future announcements likely? Are there any consumer campaigns brewing that could affect your work? So just a few examples of pitfalls that we faced and how we overcame them. Firstly, around consent. As mentioned, we started with a belt and braces approach, which meant that every time a patient was seen, the practitioner was expected to ask the patient whether they were happy for their record to be shared. It soon became apparent from ED, emergency department, that on Friday night in Bournemouth, when people were rolling and unconscious from the drink, this was unworkable for practitioners. However, other partners were very wary of relaxing their stance, saying that this is what we've always had and we're not willing to change. Others felt that they needed to do more around checking their current consent and record status, and we basically reached an impasse, which meant that few people were prepared to use the DCR. After months of discussions, we realised that the GDPR regulations could enable us to move to a public task model. We needed the support of the ICO office. Members came down for 2 days of discussions, and we were given the all clear as long as we carried out a county-wide leaflet campaign, radio advertising and other media. In fact, the media campaign won a highly commended award in the Health Tech News annual competition a couple of years back. In retrospect, this was a cultural issue. Different partners had and still have different thoughts around the issue. This is Durdle Door. Dorset is indeed a beautiful county, but it's not immune from the forces of political change. With its large number of district councils costing the taxpayer money, it was always likely that the county would move to unitary authority status once pressure was applied from Whitehall. This rationalisation from 9 districts to 2 unitary bodies has at times been difficult, with staff switched from DCR work to other activities. And this has had to be a rationalisation of feeds too for adult services at BCP. It still hasn't been fully resolved for us, but we are still getting numbers of staff joining the Dorset Care Record and continue our engagement with adult services at virtual and actual events. Another pitfall has been encouraging staff to understand that the DCR is different from other systems. I liken it to the hub of a bicycle wheel, which has feeds or spokes coming into the centre from across our partnership. But for many in the early months and years of the DCR, they said, we have access to SCR, Summary Care Record, we don't need DCR. There's nothing in addition that can be gained. For some, it was a case of educating folk. For others, it was a case of waiting until more feeds, such as radiology, pathology, discharge medications, clinical correspondence, came on board as the DCR matured. Single sign-on or click-throughs from partners' electronic patient records has made a huge difference, leading to a rise in numbers from 19,000 patient records accessed in January to 52,000 in October. Promotion of single sign-on has really helped. Some partners, of course, are information rich, such as GPs, and it has been difficult to reach out to practice managers and GPs. We've tried a range of tactics, as you can see, and it's beginning to pay off, but there is still some scepticism. We sadly lost one of our GP advocates, Dr. Craig Wakeham, the Chief Clinical Information Officer for Dorset CCG and St Abbas GP, to COVID last year. He was a great advocate for the DCR. I suspect a combination of single sign-on, ongoing maturity of the record and enhanced interoperability between Hampshire and Dorset through the work of Wessex Care Records will help. So what next for the DCR on that long and windy road? I think one of the most exciting areas of work is the development of the patient health record, My DCR, which will empower people to take control of their health and well-being. Linked to the DCR clinical portal, the patient record has been likened to a digital health passport and is one of the key challenges for our Dorset digital technology moving forward. You can see that in time it will incorporate a large number of other digital programmes, including My COPD, My Heart, My Asthma, My Diabetes, the maternity and cancer patient portals, remote monitoring diagnostics from home, and the Orca Health Library of resources. In time, it will link to the NHS app. Each partner will be playing a role, and we're kicking off pilots around My Support Network called Circle of Care and clinical letters from DCH's rheumatology teams next month. It's a very exciting piece of work, but needs careful communications handling to manage expectations, particularly as we are starting off very small. We'll be looking in the future at potentially robotic automation to onboard people, but we really want to and need to walk before we can run. There are here are some, but certainly not all, of the pieces of the work that we're going to be doing around communications engagement. And one area that I'd like to focus on has been the establishment of a user group for the My Support Network pilots, which involves inviting friends, family, others to see records. The user group has included stakeholders, People First Dorset, Dorset Carers Hub, Dorset Race Equality Council, Bournemouth and Poole Carers Group, members of the public engagement and patient participation groups, and individual cancer patients and academics who have been willing to give up their time for free to help us. Some have been on a long journey since we first held our first stakeholder meeting back in early 2019. Others are new. They've also given their input into all the leaflets, posters, videos, one-pages, FAQs. My DCR is for the people. Their input is essential. Listening is key. So time is running away. I wanted to say a little about new partners who are looking to come on stream. Last year, due to COVID, we fast-tracked 2 partners to give them access to the DCR. Yeovil Hospital takes up 40% of North Dorset's patients, and they had been very reliant on getting information from GPs. And at the start of the pandemic, we're very keen to have 150 clinicians given access. We managed this in record time, and their Deputy Chief Medical Officer, Paul Foster, said, quote, "It is great to be able to overcome these hurdles and provide a more enhanced, joined-up approach with our Dorset healthcare colleagues, with the patient's needs at the centre of all we do." Similarly, community pharmacies were keen to get more information around discharge medications from hospitals, and we've granted them access. Take-up has been great from the independents, less so from the national chains, which find it harder to incorporate local changes digitally. Others have come forward, including Salisbury Hospital, which takes patients from the northeast of the county, from the lovely rolling hills of the Cranbourne Chase. Avon and Wiltshire Mental Health Services, Marie Curie, Age UK. They do need to sign up to the DISC, the Dorset Information Sharing Charter, have secure networks, be contracted to work for one of the partners, be CQC accredited, and we need to run these past the Pan-Dorset Information Governance Group. But it's a really encouraging sign that people want to join us. And finally, we're embarking on launching very soon our diabetes pathway, and I wanted here, rather than talk tech, talk about the importance of knowledge transfer. Our pathway is based on the successful Northern Ireland electronic care record, which has been successfully rolled out again across the country and is really making a difference both to clinicians and others on the fringes, such as podiatrists. They have been fantastic at sharing information, allowing our leads to come and shadow their clinicians, and providing ongoing support and expertise. So thank you, Northern Ireland. And so finally, my top 10 take-home messages around communications engagement. They're all important. I have put them in an order. You may agree, you may not, you may disagree. So in at 10 is managing time effectively. I've always been part-time, ranging from 2 to 4 days a week on the DCR. So prioritising work is vital to meet those deadlines. Don't work all hours, despite the temptation of getting that laptop out at 6 in the morning. Do take breaks, do go for walks to help with your mental health. At 9, don't just talk, hear and listen. I'm always much happier when I present to a group to have heard them for at least 15 minutes. You can understand the dynamics, the knowledge of the group, the patience, the tolerance levels. There is nothing worse coming in late to a meeting and being told you're on straight away and not understanding the audience, as happened a couple of weeks back in Poole Hospital when I came back to talk to cancer clinicians. I started at a level where I thought there'd be only to be told 5 minutes in that they knew very little and having to restart from the beginning. Before doing so, I listened to what they really wanted to hear. Back at 8 is positive feedback and diplomacy. We work in a small team and some of us have seen each other only once in person since the start of COVID. We're all very different characters. Some are extrovert, others introvert. Some want to drive things forward at pace, others to cogitate and discuss. With COVID, it's been hard to get to know new employees, so be diplomatic and be as positive in your feedback as you can, because I find it really builds trusts and relationships. So at 7 is knowledge transfer. I've already mentioned our work with the Northern Ireland Electronic Care Record, but I'm also a member of a group run by Connecting Care in Bristol, which includes Derbyshire, Cambridgeshire and Peterborough, Wessex, Hampshire and others. And I have monthly meetings with my CHI counterpart, Catherine Guthrie. I've talked about our comms approach to East Anglia and to Manchester and others. Sharing your knowledge is important. It can help save time, money and resources. At 6 is sorting governance and IG out, and it's really important that you as a shared care record do this, but also that staff are up to speed with security, privacy and sharing issues. Our local authority here in Dorset is very good at making us do mandatory training in these areas, not just once, but every year. The last thing you want is an information breach and the Commissioner's office fining you, breathing down your neck, because you've lost all credibility. Interesting one, this one. Do you have the right people in the right posts? Here's a picture of our team, and of course they're all in the right posts. This was our volunteering day at the beautiful RSPB Reserve at Arne. With something like the DCR, you do need to be advocates, disciples, evangelists almost to help carry out change. You don't need to be salespeople and shout. The still small voice of calm is equally and often more effective. You've got to believe that data saves lives and that your work is encouraging greater fairness across our healthcare system. In Dorset, we have very wealthy areas, but also very poor and impoverished regions, particularly around Portland and in parts of Bournemouth. Be prepared to change at pace is at 4. Your customers may first of all say that they want X and then reconsider and demand Y. And in the end, they plump for Z. And sometimes as a comms professional, that can be so frustrating. You produced a range of materials for X and it can't be used. So you start again for Y and then again for Z. But actually, isn't that part of life's rich tapestry? Nothing in life is ever straightforward. It's how you react to the change that's important. So top 3, and I put 3, know your audience. One of my worst nightmares that I still relive today was when I was farming editor for a daily paper not far from here. I was asked to do an after-dinner speech for a cattle society. I don't really know why. I'd never done one before. I thought I'd do some dedicated desk research into the cattle society, point out the benefits of Roy's Castle Line genetic pool, and then talk a little about me with a few disparaging jokes. It was not a nightmare. They wanted Jimmy Carr or Tim Vine. They got Tony McDougall. I was outside my comfort zone. I didn't know the audience. It was a disaster. Fairly basic, this one, and some would argue it should be number 1, but have a story to tell. Talk up those benefits, give financial figures if they're robust. Lace your articles, speeches, news items with relevant and meaningful human interest case studies, and remember to get the best bits out first. And top of the charts is that word that we all love, evaluation. Get your metrics right, whether it's campaigns, face-to-face meetings, polls, so that you can show your leadership how your work is contributing towards successful policy outcomes, providing clear evidence of impact and value for money. Or in civil service speak, effective iterative monitoring and evaluation will help you to articulate the quantifiable value and benefit of government campaigns and programs of communications, and provide actionable insight to improve campaigns on an ongoing basis. Do share the results with your colleagues and ICS local authority leads. And perhaps the last 2 slides are important too. Be creative, enjoy yourself, stamp your mark on the project that you're working with. People prefer different comms channels, and we produced a video infographic based on this slide. We've also commissioned the fantastically talented Dorset Council artist Sketchy May to produce this wonderful drawing of what the DCR is all about. And this sums up to me what the DCR is. It links health records and information digitally between GPs, clinicians, social workers, nurses, and the public, you and I, to empower us all. Thank you very much for staying with me. Thank you.